Dr. Rekha Mishra for her case.
Respected Chairperson, and good afternoon, everyone. First of all, I would like to thank Dr. Rakesh Gupta, sir, for inviting me here. It's truly an honor. I am presenting an interesting case of a 37-year-old gentleman presented in the emergency department with chief complaints of acute chest pain radiating to back since early morning the same day. Past history, no known medical or surgical comorbidities, and he was a chronic smoker. On examination, pulse was 78 per minute with normal sinus rhythm. BP was 100 by 60 millimeters of mercury. And on CVS examination, S1, S2 was muffled. There was no murmur. Chest showed normal vesicular breath sound, with no added sounds. So an urgent echo was advised, and we did in the emergency department only. So starting with the parasternal long axis view, the first echo clip itself is diagnostic. We can see that the most striking feature here is the ascending aorta, which is markedly dilated, and there is a linear echo density in the ascending aorta, suggesting that it was a dissection flap. The LA is compressed, and even the RV is compressed. And anteriorly in the pericardium, we can see that this soft tissue echogenicity, along with echo-free spaces, suggesting that it was a hemopericardium. And we can see the dissection flaps very clearly, both in the anterior as well as the posterior walls. And the ascending aorta measured was 6.8 centimeters. In the third clip, we can see that the flow is seen only in the true lumen of the dissection, and there was hardly any flow in the false lumen. Good LV systolic function, and in the third picture, we can see that it was a bicuspid aortic valve, which was mildly thickened, but it was moving well. LV systolic as well as RV systolic functions were preserved, and in the second picture, we can see the dissection flap. It is quite away from the aortic valve. Mitral inflow shows marked respiratory variation, suggesting it was an exaggerated ventricular interdependence, and IVC was dilated with no respiratory variation. There was dissection flap also in the arch of aorta, and in the abdominal aorta also in the third picture. And there was flow both in the true as well as the false lumen in the abdominal aorta. So an urgent the CT aortogram was done, which confirmed the diagnosis of stent 4 type A dissection, extending from the right from the ascending aorta up to the right common iliac artery. And the good thing was, the good plus point was that the coronary arteries, the arch vessels, and all the major branches of the abdominal aorta were perfused through the true lumen. So it was decided to operate him urgently, and pre-operatively he was stabilized with IV levotalol, and an consent for urgent surgery was done. And these are the intraoperative findings. The moment the pericardium was opened by the surgeons, blood gushed out. So it was a hemopericardium and cardiac tamponade. And entry tear in the root just distal to the right coronary artery was seen. No tears in the arch. Arch vessels were normal. Bicuspid aortic valve. C was type 1 with right RCC and LCC were fused. So he was operated upon, and post-operative period was uneventful. Mechanical Bantal procedure was done with ascending aortic plus hemi-arch replacement using 26 Dacron prosthesis. So post-operative period, he was absolutely fine. And these are the post-operative echo pictures. We can see that the RV has come back to its normal size. Even the LA has come back to its normal size. LV systolic function is preserved. And no MR ascending aortic conduit was normal, with peak and mean pressure gradient of 19 by 9 millimeters of mercury across the aortic valve. LV systolic as well as RV systolic functions were preserved. There was good flow in the descending aorta also, but the dissection flap persisted in the abdominal aorta and in the abdominal aorta. And post-operative CT also showed that there was persistent intimal flap in the distal arch, the descending aorta, as well as the abdominal aorta, extending right into the common iliac artery. And the review of literature shows that aortic dissection is a rare but lethal pathology, and incidence is 3.4 to 4.4 per 1 lakh persons per year, and higher risk in males, that is 2:1 ratio. And the most common predisposing factors are advanced age, male gender, hypertension, Marfan syndrome, congenital abnormalities of the aortic valve like bicuspid or unicuspid valve. And there are two classifications of aortic dissection, the DeBakey type 1 and Stanford type A and B, based on the involvement of the ascending aorta. Stanford type Stanford type classification is more used commonly nowadays because it's more attuned to the management of the patient. And depending on the timing of onset, it's divided into 4 types, like less than 24 hours hyperacute, acute 2 to 7 days, and subacute 8 to 30 days, and more than 30 days is called chronic. So multimodality imaging is important to diagnose aortic dissection, because the early diagnosis of aortic dissection and the associated malperfusion syndrome is vital to prevent mortality. Treatment, Stanford type A, surgical management. Stanford type B, if it is uncomplicated, then medical management. And if the Stanford type B is complicated, then surgical intervention after initiation of medical therapy. And nowadays we are using endovascular stent grafting, that is called TEVAR. Thank you.
A great case, ma'am. And in this case, the age of the patient, which was 37, the dilated aortic root, the bicuspid aortic valve, and the target organ damage, which we could see in the form of concentric LVH in this patient who was hypertensive, all were predisposing, and the pain radiating to the shoulder. We should not miss
it was
this
very
sign. And the patient was in
classical,
cardiac tamponade. It all went in favor of the ascending aortic aneurysm. Any comments from the panel?
Thank you, ma'am. I think I'm just a question. Do we have recurrence in this case also after surgery? Redissection, is it reported?
Recurrence after surgery.
After surgery, I'm just thinking.
There can be like the till arch, it was hemi-arch, it was replaced. And if there is, because there was bicuspid aortic valve, so aortopathy is always there. Not always, most of the time it is there. So the descending part of the aorta or abdominal aorta, they can have this aneurysm. So it can extend.
So your echo was life-saving in this case. Thank you, ma'am. Should I call Dr. Payal Nindra for her case? Is she there? Dr. Payal Nindra? Not there? No. So any further comments from the panel for the regarding all the 4 cases?
So all the case shows that the superiority of the multimodality image in 2025, and it shows that the one modality cannot see the whole picture. You have to use multimodality for getting 360-degree view of the whole picture. It can be said that, like already earlier in the morning said, that now it is a modern day stethoscope. And one can say that seeing in a single modality is like a seeing in a black and white, and seeing in with multimodality, it is like a 3D IMAX vision. So all the case has shown the importance of multimodality imaging, and all the pictures were very good. So thank you for the great cases. Can we move to the next case?
No, I think
Yeah.
this was about all. Actually, we 2 presenters are missing. So this comes to the end of the session.
Oh, so any question from the house?
So I think we can move on to our next session.
No,
And
thank
before
you,
that,
thank
I
you.
think we can all gather here on the right side of the podium for the felicitation ceremony. Dr. Rakesh Gupta, sir.